I'll start today's EGM conference. This is Junyoung Lee from Severan Hospital.
I cannot go ahead.
안녕하십니까, 조세요?
거기를 꺼야
이거를 살리고
네,
왼쪽에 마이크 꺼야 될 겁니다.
지금 합니다. The patient was 56 years old male and reported for intermittent palpitation and has no special pathological story. And his echocardiography showed mild relaxation and normality, but nothing else is special. It's 12 weeks.
Actually, what is characteristics of the patient palpitation? Referral for palpitation is not a history, right? You need to describe the specificity and the characteristics of a symptom, right?
His palpitation was started 3 years ago and sudden started and sudden stop again.
Duration, frequency,
Duration is several minutes, and he felt the symptom more frequently recently and every day, almost every day. So this is 12 ECG from outpatient clinic, and there's no more signs written. But this is ECG taken from another hospital 2 years ago when he felt a palpitation, and it shows tachycardia, like 1.2.
So can you, when you present, go back there. Let me show you something. In sinus rhythm, you go back sinus rhythm ECG, please. Okay. In sinus rhythm ECG, you don't see much difference. But the problem here is what? If 56 years old, this QRS here, width is normal, you think? They're slightly wider than usual, right? Would you expect this a little sharper? And then the axis, you have a Q in lead 3, right? What does that mean? A little bit more toward the leftward superior, right, than usual, but that can be because the patient's body mass, maybe short chest, or many other things. So for you to be an electrophysiologist, you need to start looking those things, because as Dr. Bach points out, the history says you said that 3 years intermittent on and off. That already tell you two stories. Differential diagnosis, either re-entry or going to be trigger. Cannot be ectopic tachycardia or focal automaticity like a sinus rhythm. So this history is meant to start thinking, oh, this could be this type of disease, not that one. So you start excluding from the story it goes along. So that kind of a rational thinking process is important in the training. Okay, go ahead. Sorry, interrupt you. So if you look at the tachycardia now, or EKG tachycardia, what do you see compared to sinus? First of all, P wave, how that looks like. So totally ECG, take a look. Your EKG, that's a very important. Now, that previous one, go. Yeah, this one. Describe to us. You see, how about this P wave 2, 3 AVN?
2, 3, imperial lead.
Imperial lead, and then your P to the R is what? They're long. In other words, AVNRT, usually P wave retrograde to follow the QRS. This is different. This is a patient of a R wave preceding the PR wave, preceding the inverted. And then the V1 is biphasic, right? And then leftward axis is indeterminate. Okay. So then you start thinking, oh, there's a certain diagnosis, long RP tachycardia patient. What are the difference of diagnosis? When you read the textbook, they will tell you all that. So that thinking comes into this equation. Then you make a difference of diagnosis. Okay, great. Okay.
of course, the P wave axis apparently differ, but why the PR interval is shorter than in sinus rhythm? What do you think?
Maybe the
Probably
very short. So maybe I thought this is atrial tachycardia and originate from the conduction system.
originate from conduction system
이게 PRS short, QRS
near the conduction system.
near the conductions.
Right, so he's referring as a junctional tachycardia, for example. This could be P preceding R, but also could be some sort of reentient tachycardia. The ventricle is part of just bystander. So relationship to the PRS doesn't matter. Make sense? The AVNRT, for example, that's the reason that you don't need a ventricle to have AVNRT. That's why sometimes can be short RP, mid RP, long RP. Make sense? And that's a manifestation. Okay. We're trying to not to stress you, so we're trying to teach you. Okay. So relax, that'll be fine. Okay, go to the next tracing. What do you see here?
Okay. P-wave at the brilliant showed biphasic but terminal negativity.
Mm-hmm.
Imperial read is dominant.
Right.
And read 1 and AVL shows positive
Okay.
P-wave.
Mm-hmm.
And we did the Holter monitoring and showed a similar pattern.
Mm-hmm.
And report said sustained atrial tachycardia with frequently. And his X-ray shows normal. So we did the electrophysiologic study.
So your indication of EP study is first you have a documented clinical tachycardia. Frequency of symptoms are quite frequent. So tachycardia burden is a significant. Yeah. So you need to, when you write a report, you need to state that. Because in the United States, for example, they will not pay you unless you document it with the indication for the procedure there. Okay. Second most important thing that I'm going to start telling you guys now, from now on much as I can, legal issue comes up because your procedure can have a complication. Then lawyer are going to first thing look at it. This patient really needed a procedure. Did you document it in your paper? Those issues you need to start to become more familiar because Korea, I can see now, ever increasing instance of medical legal litigation. So protect yourself. Okay, so make a habit of documentation clear. The chart is very, very important. Okay, all right.
This is
So you go back to this. What do you say about the Holter monitor there? What did that say? Is here asymptomatic premature 10%, ventricular complex 3%, the non-atrial tachycardia 38%, atrial tachycardia maximum 2,117. How do you cope with this data in conjunction with the tachycardia? What would you favor for? So differential diagonal you can make out of this, right? So what do you think that this is still ectopic tachycardia or is long RP tachycardia including AV and RT? Also the possibility that maybe there's another P wave inside the T wave. We are not seeing it 2 to 1. Then HR rate would be double as the QRS complex, right? So all these different possibilities you need to open because this patient has a frequent PAC, and then which can trigger sometimes atrial fibrillation, atrial flutter, AVNRT, all this. So you need to address that issue late during the ablation. Do you want to ablate this PAC, yes or no? You need to know those things, right? So this is an important part of our equation you have to put in your mind. Okay.
There was a question on the chatting window. So did you see cardiomegaly? Dr. Kim Min asked you.
Oh, I don't see the.
So roughly for you to have a rule of thumb in chest X-ray evaluation is first quality of a chest X-ray is a good or bad. Okay, is over penetrate, under penetrate will not scare your heart size. But the chest X quality looks okay. Then what you do, measure cross diameter of a right lateral border to the LV apex put up. Should not pass more than half of the hemithorax. Usually about 40%, 45%. That's normal size. That's how all the professors of radiology teach us. This is borderline. And then you look at the patient's apex. There's a little bit kind of a lifted up pattern rather than dip it down. The cardiac border should come down left side more smooth downward, not just kind of bulge out like a boot shape. Remember we used to learn at the chest X boot shape? Those are people who have a lung disease or right atrial overload have this pattern. But this could be because the patient is overweight, lying down as well. because the diaphragm abdominal pressure comes up. So when you deep breath in, still high pressure in abdomen, the diaphragm is still high. So this, all this for variation. But if you look at the soft tissue thickness in this patient in chest X-ray, body size is not that small. Look at the soft tissue. So even the lady, probably a little overweight side, looking at the chest X-ray. Okay, that much I can.
We can explain why there was a Q wave and lead 3. Because of heart position.
Yeah, but EKG already told you that the heart is lifted up, right? So this is that. That's all goes together. That's how all the teachers used to tell us all this stuff, just looking at this story. Okay. Go ahead. We're trying to keep you more feedback as you can. You're in training, so we want you really learn more. Okay.
We did a visual study, and this is the initial catheter positioning. Here the coupler catheter is in the coronary sinus, and the coupler catheter is in the RV, and quadripolar at the his area. And tachycardia was induced during the catheter positioning, where the tachycycle length is about 544, 554, and VA is very long, 429, and AV is 129. And earliest activation is at the distal his.
Now these are his EGM, what we saw showed early, right? But how's the morphology about EGM? It's changing. So from first to beat is your distal EGM barely visible, far field. And then as the catheter moves into the ventricle, because of your proximal his A becoming smaller. Can you see that? His 1 to 4. Take a look at his 1 to 4. Next. Yeah, that one. Go to the left. Go, keep going, keep going, keep going. Yes, you see that A? You can see very nice sharp A there, right? Go to the next bit. Go to the next one. Next complex. Yeah, that's to the pointer. Yeah, right here. This. You see?
마우스로 따라가 주세요.
That one. Next one. That's the one. And then next one. Last one. Almost barely visible A there, right? So that means your his catheter probably very unstable here. And I don't see his bundle EGM. So I'm not sure you can tell in presentation, this is his EGM, okay? So when you're presenting in the future in a conference, you want to make sure that find the tracing that has a his bundle potential. Then you can, what you're saying is true. But without bundles in his bundle potential, you cannot say his discharge earlier, okay? So that's not usually, what we accept. Okay, so septal A is earlier. Let's put that way. Okay.
And we took a 12 decision here, and similar morphology with documented PG 3 years ago with 2 on 5 page P-wave with terminal negative and inferiority is dominant negative. And there's sometimes that tachycardia is still a little wobbling, and at the point the AA interval frequency change in breathing interval. We tried breathe free reset. There's no effect. We tried several times with no effect.
Okay.
And we tried ventricular overdrive pacing, but in tachycardia, VA dissociation was showed. So cardiac terminates. Terminates. We measure the general focal study. In sinus rhythm, cycle length was 787 and AH was 74, and HV is 54, and QRS duration is 101. And we started RV pacing. It shows a concentric activation. And at the 500, we reached the VA block cycle length. And we started the single ventricular stimulation test. And at the 600 and 500 540 to 520, we discovered 3A jump. And we reached the ERP, the 600 or 40. So 600, 200, we reached the VERP. And we started a study. At the RIP 420, we reached the AB block cycling. And at the single arterial stimulation test, 600 and 470 and 600, 460, tachycardia was repeatedly induced. At the tachycardia self-terminate, we tried again, and same point, there's a AH jump. 600, 472, 460. And reached the ERP at the 600 or 20. And there's an AERP, 620, 200. So this is the diagnostic summary. At the 12-lead ECG, we found the PA-based 5-page terminal negative at V1 and positive at read 1 and ABL, and dominant negative at our inferior read. And during sinus rhythm, there's an antegrade and retrograde concentric activation, and VA block cycle length is longer than cardiac cycle length, and there are VA jump and AH jump. And during tachycardia, early state activation was at ease. VA time is very long. And at the wobbling, AA interval precedes change in VV interval, and there was no A reset or V reset. And VAD during ventricular overdriving pacing, and tachycardia induced by single arterial stimulation. So the impression is atrial tachycardia originates from the paraxian area and simultaneously dual AV nodal physiology. So we tried mapping after isoproterenol infusion, tachycardia was induced. So we tried mapping from the RA side, but the earliest activation at grid was about same time with this. We decided to approach at the left side, and actually was punctured and aortogram stone, and also the geometry mapping was done at the aorta. And this is a mapping from the aorta, and earliest signal at the grid was earlier with 60 milliseconds at non-chronic cause. We put the ablation catheter. And starting ablation at that site, the NCC. And tachycardia was terminated in 4 seconds. At the first ablation, and we use isoproterenol again, and RIP 400 millisecond induced the tachycardia. The same morphology. The cycle length was 510, and earliest signal is at the his. So this ablation were done 2 times, and during the ablation, it was terminated. This is the final result of ablation.
Which one is his and which one is ablation point?
Like a red is his bundle. The ablation in the aortic cuspid looks like,
Red, that, those
This-
are,
and this.
those are
Right.
his.
Mhm.
Why don't you show us the activation map? This is bullish map.
Try to find it. There's no good picture to show them.
No good picture. Then how did we map?
3D.
It's really a late map. We should show that.
So if you convert this map to the propagation map, that's what he's asking. This is the voltage map they showed you. Now the voltage maps you often is not very useful because around the aortic annulus is going to be low voltage throughout anyway. Okay. Now the was there any other clinical clue this might be different tachycardia or what you're thinking, but that was at the beginning with this? What do you think about that? In other words, we already talked about ectopic atrial tachycardia, AVNRT, atrial fluoro two-tone conduction, all that stuff, because the patient has a typical clinical pattern. Now, in clinical history that you point out very well, an echocardiogram, this aortic cuspid atrial tachycardia, subtle atrial tachycardia, very common in diastolic heart failure patients. And as they get older, incidence increases. There's one more typical feature of that is that you show the B1, you show the EKG in B1. Take a look at the B1. It's really negative or they're biphasic. Probably CGB B1, take a look. You said the clinical ECG right there, B1. Is it negative or biphasic? Biphasic, right. So they're slightly different than AVNRT. The reason is AVNRT originating by little inferior, posterior. Aortic tachycardia come from higher, little more anterior. So B1 is here. So think about it. Yeah, I come up to the closest anterior, it's gotta be biphasic. Okay? Because it's gonna activate first and then turn around. AVNRT always coming from below. Therefore, whether you're long, short, tachycardia or intermediate or typical AVNRT, it's going to be always negative P wave. So you need to be very important differential diagnosis. And another thing is that this patient has a chest, the clue that is in the chest X-ray. Because the patient, Dr. Bach pointed out that the patient has already good-shaped heart, and then she has already diastolic dysfunction. It's a classical feature of ectopic atrial tachycardia aortic cuspid. Now, I'm surprised you did not map left atrium. Why you did not map left atrium? May I ask you that question? And you never thought about this because we left atrial tachycardia. Why is that? That's going to be more important maneuvering during the electrophysiology laboratory, what you do every day. So if you typically say that the his bundle activation is earlier, and I bet that's not early. Go back your tracing. I just curious about that. Go to intracardiac signal with the tachycardia. Okay, right there. No, that one. First, yeah. You told me that they are early on the his bundle. How about this RV 910? Where this is? 7-8. Where this thing is? Do you know where the location is? RV catheter.
See,
910 7-8. What it is? Show me X-ray. Where's RV catheter?
It's overlap with his.
No, this is RV catheter, I assume, right?
Yes.
The long. So 7-8 here at 910 is this one?
Yeah.
Okay. And this catheter indeed was his bundle catheter. Okay. Your original diagnosis. What it is. Go down. I'll show you what I'm talking. Okay. If you look at it carefully, his bundle here, okay, clearly seen subtle A here. Maybe feasible his bundle, possibly, I would argue. Then if you draw the line here, this valve is early here, not there. So this ectopic atrial tachycardia already coming from septum down wide range because you got 3 electron space, almost same activation. That signal of far field. So in other words, that's why important to get the EGM, okay? This is a near field, this is a far field. That means coming far away from the east bundle, which is earlier. That's your ablation index. That's you gotta be bipolar EGM, close to that one to target that. That already alone, this tracing tell you this is not an ABNRT. Make sense? So try to correlate what you find in intracardiac EGM, interpret your image. It's very, very important to do that during the procedure. That's why when you put a catheter initially baseline, try to not to dislodge the catheter because it can change activation pattern and you get very confused about it. And one more recommendation I have, go back to your film, chest X-ray, as a scintigraph catheter position. Okay. If you look at the LAO view, it's perfect. Why? Because the his bones are coming at you. Okay? RAO view, no. You gotta make a little more RAO. So open that up. So CS become line up like this. Okay? Then you can see the septum bigger, wider. This is not a proper way to look at your septum. That's what I'm trying to tell you. So AVNRT, right real pathway, whatever, CS need to be in the line. That tell you another thing. When your catheter is in the contact with the focus, you will see CS, your oblation move together. You can see much better way that way. Because you oblique, CS catheter kind of twists around a little bit, then you're going to be confused about it. So this is a classical focal aortic cuspidity and non-coronary cuspidity atrial tachycardia. That's very common. And fortunately, you're able to do that. But my recommendation is next time you see this type of tachycardia, when such a broad activation earlier in the septum, map the left side. You will miss left atrial tachycardia. Okay? So it is important to do right septum, parahystem mapping, cross left side map, and then aortic cuspid. You put together and then decide where you're going to ablate. Okay? That's a complete mapping.
At the time I mapped the Buckman's bundle area, fossa ovalis, and SVC, but all those were later than the East bundle A. So that's why we tried the 3D map of our right atrium. But still, the right atrium, I didn't see any earlier point than the East bundle A. That's why I mapped the aortic cuspid.
Right.
But when I was young, I tried to map the LARA and aortic cuspid all together, but I never seen the successful ablation from the left side septum so far.
It's not a septum. Go back there. Do your mapping. Okay, go back.
3D map.
3D map. Okay, I want to remind you importance of a non-coronary cuspid anatomy now. Okay, all right. If you should look carefully, non-coronary cuspid, okay, here, split half, anterior contact with the right atrium, posterior half, left atrium, anterior septum.
Right.
So there's a tachycardia. If you put, let's say that you put the aortic cuspid catheter, you did not find a good electrogram, but you find the intracuspid, earliest electrogram more posterior, that's a left atrial tachycardia. In other words, you can get such information from coronary cuspid alone already. So therefore, safer to ablate from left atrial tachycardia than aortic cuspid tachycardia.
I have several experience of left atrial anteroseptal atrial tachycardia ablation in patient with AF.
Yes.
But this is
no focal tachycardia. Also, we've seen that. Yes.
Are you saw that?
Yes, we've seen it. That's why I don't want to miss it.
And
otherwise,
all those patients associated with atrial fibrillation, so their
muscle bundle
coming below the aortic cuspid, and if we successfully ablate the left side septum, access to the right side,
but
closer and closer to his bundle, and high chance of.
Yeah, so this is one of the tachycardia that you must map the left to make sure that they rule out, because there is a anteroseptal left atrial tachycardia behavior like this, in invaded septum like this coming down. So it is a differential diagnosis. You have to measure in the lab. Okay. Obviously, you do whatever you want to do, but the classical standard teaching that we learn over our masters that when you see parahystem right side focus appears to be map 3, make sure that you don't burn too many times. Otherwise, keep burning and then it doesn't work and then go to the left side. Now you got 2 area burned. Parahystem supra aortic valve and the left side. And the chance of heart block is much higher when you do that because your his bundle cross right through between. Okay, so that's the importance of avoid the complication. Map thoroughly this map. Can you do this with a 2D? Answer is yes. You can do this tachycardia 2D ablation. We do all the time. Okay, you don't need a 3D to do this. And the one person you did not show us a good ablation EGM. But take a look at your ablation EGM. Go back. Your ablation before you said successful first ablation. Yeah, you ablation signal. I don't see here. Go to
또 있잖아요.
또 전에 하나 있었던 것 같은데. Before. Yes, right here. Look at the signal here. What do you see here? This signal. This signal is not the what you marked in the grid though. Grid said of something 50 something over here. That's wrong marker. That's artifact.
이거만 하나 또 있지 않았었어요?
This is the only one I think I saw. Go back.
이게 첫
Yeah,
번째.
this is only
아니
one.
더 스윙 스피드 빠른 거 있었던 것 같아요.
This is the only one I think I saw. Yeah,
Well,
this is a grid mapping. You
Yeah,
see,
yeah.
I'm talking about this garbage
Right.
here. You can tell this is EGM because you got two different quality EGM here. I don't know what that it is. Is atopic tachycardia this long? This you mapping for inside the aortic cuspid? No, no. I think I bet you it's artifact because you go back there, ablation signal now. Ablation, yeah. Look at the timing. Much sharper signal. This is EGM. Okay.
Because
So-
I pushed the catheter.
Yes. So in other words, if you want to ablate this catheter position, I don't know, I saw your ablation, fluoroscope image or not, show the ablation catheter. It's an important one. Okay, here, you done aortogram this patient, is the right thing. Now, this catheter orientation, you think it's a good? You want to point down ablation this way, or you want to go this way? Which way you want to try to go? Think about it. This is you're pointing down the valve, floor of the valve here. Okay. So ideally ablate this, you need a small curve ablation catheter. And then you want to point the shaft to the left side and curve it like a J shape. Push it, open it. Then your catheter will be lying across the aortic valve like this. That is the right way because you're pointing to the wall. The reason I say that is if you ablate irrigation catheter, no new catheter, contact sensor, all this stiff catheter, push it down hard, you make a hole through the valve. So you need to be very careful. There's a many cases of aortic cuspid PVC ablation case, post-ablation fistula, perivalvular fistula in the United States, end up doing valve replacement. So I really want you to think about this twice when you do that. Make sure catheter oriented more lateral. Okay, it is a requirement, absolutely. Because the left side, the cuspid is just does naturally because you point the catheter curve like this. Right side very hard to do. So that's the reason that I do not use 3D mapping catheter.
Dr. Wang, your technique
Mhm.
mentions that the below valve approach, right?
No, above.
Above valve.
So what you do, come in here and then go towards the motor left cuspid first,
Mhm.
and then tight the small J curve and then rotate. So
Yeah,
you'll be
when
flying
it-
like a J.
We need a small curve.
Small curve catheter. You don't have a 3D small curve catheter in Korea, not in the United States. So I do not ablate this area with the irrigation on any of the 3D. This is a very superficial area. Even 25 watts you can get it with this thing. Contact is good. So there's no point of burning high power. Okay. In this view, it looks a little bit better. You see that area view? Okay. You should point it a little more up. Yeah, here. Cut the curve to the posterior a little bit, which is good. But then in J curve, when you do that, it's almost perpendicular. Okay. So that way you can truly push it then against the wall.
I
That's
don't
it.
believe this tachycardia really coming from the non-chronic cusp.
Yeah.
Is it below cusp?
No, I don't think so. You don't go with the below cuspid, he's bundled there. As you soon as you drop in, you're going to have his bundle, non-chronic cuspid.
There's the septal atrial bundle
Right.
below the non-chronic cusp. So the reason why I prefer the chronic cusp approach rather than the left atrial approach is catheter is very stable.
Yes.
Even though it is not coming from the cusp itself,
You
the
blame factor.
yeah,
Yes.
RF panels can penetrate.
Right. But
the septal
catheter
atrial
stability,
bundle.
all that is the issue, but to make sure that you don't cause aortic insufficiency, though. That is the only reason that we are talking catheter manipulation. Okay. So is it catheter needs to be soft, cannot be stiff, and then you make sure they're pointing more up. Okay. because you're coming from annulus, not coming from leaflet. That's what I'm trying to tell you. Okay. That's why you have that long fragment signal on the ablation EGM, sharp. Look at this ablation sharp. This top right here. This is a spike. That's a local potential, rest of the far field. Okay. And then your catheter is the right orientation, is the proper Y. Distal, go back there. Distal EGM earlier than proximal, which is already far field. Because the proximal then is not in contact, only distal pivot is in contact. Okay. So space is very small. So that is a way to make sure that the distal to sequence is proximal. Sometimes far field distal, near field distal is later than the far field proximal, that means you're already too low. Is the curve up. Okay. So basically, try to pay attention to EGM at the beginning. That will always save you trouble. They will tell you, where to blade, what to do, and so on. And how are you going to move a cat the next time? Whether they're going to push you up and down, all is tell you that. Okay. It's a great case. Wonderful. Good teaching. Any other comment, gentlemen? Yes, please.
I have a question. I see the floor into.
Aorta?
Aorta block.
Yeah,
Aorta block.
Let's,
This is it.
the previous. Yes. If you only have large column,
Here, I don't know what to do.
should the
You cover there?
conductor be like this?
Hmm?
To avoid penetration.
I am not sure you have enough room to large cover to drop that tip down to the cuspid.
Then if you use large curve irrigated curve, you always have to risk valve penetration.
Right. Because you cannot make enough curve. We need to tight this curve.
Very careful.
So it is, that's for the reason that, long time ago, some people used to use the SL2 sheet, even have to curve more. So put a long SL sheet and it just curve it. But in US population, very hard to do unless you have extra long SL1 too, because very long people, big people. Korea, you might be. However, don't bother with the hassle. Just get a Celsius B curve and you'll be done with it. Celsius, okay, non-standard. EGMs of quality is better, manipulation softer, no trouble. Okay, so technology is always good sometimes, but not necessarily good for each patient. Bottom line is, so you make a decision which ones you want to use.
As Dr. Huang mentioned, generally the aortic cusp origin PVC or later tachycardia very easily eliminated by single bond.
Right.
But when I tried HD grid is softer than the ablation catheter, so probably it touched the localized right spot, but it is too soft, so contact pressure was not good. That's why initially we terminated within 4 seconds, but the recurrent tachycardia. So that's why I pushed the catheter more and showed the bigger local electrode.
Yeah.
And another point is that I saw the right side his bundle recording was very poor in this patient. So that's why if you look at the floor image later, I changed the deflect of his catheter, but still the his bundle recording was poor in right side. But when I mapped the grid catheter, left side his was very prominent.
Yeah.
So
Probably right under the his bump.
we can explain this my hypothesis, but comparing to the sinus rhythm, atrial tachycardia ECG shows a shorter period because the tachycardia focal is close to the left side spot. Okay? As you told, it is closer to the conduction system.
So if you have a dominantly antegrade fast pathway input, like this tachycardia, if you look at you describe as the VA jump, but if you look at the EKG carefully, I don't know how you guys define the jump by the conduction interval or conduction patterns matters. Go take a look. Show me your VA jump. I want to tell you something. Okay, right here. Take a look. you said there's a VA jump, okay? Assuming that he's in the right spot. If you look at during the pacing here, if you look at his bundle is here, right? But local EGM earlier is CS 7 and 8. You see it? This is earlier. This is posterior activation. So this might be already slow pathway. Question I have, when you said that there was a jump, then what happened? Septal A, all this become same. By definition of a jump, in classical electrophysiology, you have to have a fast break conduction block, go to the slow pathway, and then conduct delay more than 40 milliseconds. Not only timing, you have to see change in activation. This patient has a reversal activation here. I don't know what to make out of this. Okay, the question is, this is a constant concealment of the fast pathway. Now fast pathway woke up here is possible because normally conduct through the slow pathway in this patient most of the time because the activated tachycardia and concealment conditioning of the fast pathway got delayed. Maybe it's possible, but that's not only just thinking about it, but EGM clearly changed. Okay, so making sure when you say jump, has to have a fast pathway block to the posterior activation. That is what that means. Not just the 40 millisecond interval difference. Okay? Yeah, that's a demonstration dual evidence physiology. Okay. Yes, please.
Out of curiosity, if there is a cusp penetration
Yes.
caused by a catheter, should we just keep the catheter located there or until we ask for surgical assistance?
No.
Or
Okay, I understand that. It's not a medical emergency. However, patient symptoms progressively worse following 3 months period. Exercise tolerance start going down. And then in clinic, you can start hearing murmur very loud at the beginning. Then getting less louder because the hole got bigger. Okay? So aortic insufficiency, when the hole is narrow, very high pitch sound. So you don't even have stethoscope. You walk in the clinic quietly, you can hear some funny noises. That high pitch. Because the hole is a very pinhole, very small. And then because what happened, when you burn it, your tissue set core necrosis around the inflammation. But then pressure gradient keep pushing the inflammatory tissue, gap widen. So that usually progresses in 2 or 3 months. Yeah, I saw one patient in consultation because a patient post-ablation PVC from another center came to us, kept complaining short of breath. And she said, I don't feel palpitation, but I get after percent keep feeling short of breath. They did echocardiogram following day. After the procedure, there was no significant AI. And then her symptom onset in 2 weeks afterward onward. So then we did the echocardiogram. There was a very high jet perivalvular leak coming down. So we tried to, manage it medically. There's not a chance. So we ended up doing TAVI on her. So it is, I'm not sure if a disaster because you come to do atrial tachycardia and you end up doing TAVI. That would be a disaster, I think, at least in my mind. So I think it is something that we always have to make sure that you don't make a patient worse. Okay.
But I have an opposite case.
Okay.
It is also the referred patient
Mhm.
failed the BT ablation,
Mhm.
cause of BT ablation in another hospital. And already he shows the grade 3 AR.
Okay.
So I considered, do I have to ablate it or not? But the patient still has a
BT.
recurrent
Mhm.
non-sustained BT,
Okay.
so I ablated it. And I sent the patient to the valve specialist, and she followed the patient with medical therapy. For after 5 or 6 years, still he's good.
Well, that's
It's
a
okay.
different story because you have a central valve leakage.
Oh, it was eccentric.
Right. If eccentric part is the leaflet is leaking.
Yeah, left
Right.
leaking.
No, this is an annular leaking.
Mhm.
If you have endocarditis, if you have an annular leaking, you need to replace a valve. Same concept.
You
No
mean the
different.
annual dehiscence?
Oh, yeah, under the necrosis because you burned right at the junction. Unfortunately, because valve tissue is not vascularized. That is a problem. Okay? That's why some murmur just so high pitched when you hear. So I just look at it, wow. this is a classic bachelor examination. So I called my partner, hey, listen to this. So it is something that you need to keep in mind. So we can do a lot of bad things with this irrigation catheter. When we are using Celsius non-irrigation, chance of perforation was much lesser. So we haven't seen. Now suddenly I see this irrigation, cold tip, and all this stuff, plus the contact sensor business. We start seeing more trouble. And also we have increases in patient of subtle PVC ablation, DSD as well, because the lesion penetrate. So if you keep burning same spot, you're gonna dig in the hole and then you make a hole across the septum. You may get rid of PVC, but the patient got the DSD now. So these things happening. So be careful, just think about these things, okay?
During the LVBT ablation, I had the question from fellows from time to time.
Mm-hmm.
How can we penetrate the retrograde approach with ablation catheter safely without valve damage?
I don't think there is a safe way. If you do retrograde stiff catheter push to the aortic valve, sooner or later patient have some degree of AI, very mild or small, but I have not seen anyone without any AI. And echo guys say, oh, this is trivial. We don't want to worry about it, okay? But clearly patient had the echo before and after, everyone has a trace of AI. That bothers me quite a bit. But when I was a young, one learning EP, we had a left side posterolateral pathway, 12-year-old kid. I still remember that kid. It's just a painful memory. And then we have to do with a pediatric EP guy with kind of training with us. And we did that. He brought a patient from actually San Diego, children. And then they did a first session in San Diego, under the valve, extensive ablation, because they did not know how to transeptal. They came to us. So we did the transeptal for him. He did ablation, above, 2 weeks apart. He came back in 6 months later with a dehiscence of mitral annulus, the area we burned. Was Christmas Day. I got a phone call. I was on call. I got a phone call from some sort of fast medical center. Hey, your patient came back with a murmur. I said, wow. So send me an echo and I look at it. Wow, this is a perivalvular leak. And then exactly where we burned. So that kid, age of 13, ended up having valve replacement. I mean, that's a horrible complication. So we said, wow. Because we did not know anything about the mapping that time, or the burning all over the place. And then that is a lesson that we learned. Okay. So then we need to pay more attention, more EGM and things like that. So that really taught us so many lessons. And everyone has a complication during the practice. If people had, all patients are live who are treated, that patient have not seen, that guy has not seen peanut patient. Your patient will die during your practice of your career. Question is, how do you feel with the complication? How do you approach honestly about it? That's the most important thing. Okay. So, and then you need to also show how compassionate you are for that problem. If you're negligent, lawyer gonna get you. I can tell you that. So don't. Try to be honest. Our patient the way it is. Face the fact. That would be the best approach to this problem. Okay. That's a learning at medicine as a material physician. Is a proper attitude. Don't try to deny. Okay.
Nowadays, I'm using the extra long sheets for
Yeah, I can see
approach.
it. Yeah, but
And as Dr. Joe saw yesterday, when I do the LBG, the pigtail catheter and guide wire is small, and after LBG, I push the extra long sheets all the way to the LB and exchange. So that might be the safest way.
safest way.
And
So
LBG can save your patient's aortic valve.
But the danger is that also because of your sheet introduction directly into the LV cavity, you got longer sheet now, so you make sure that there's no clot or embolization issue. Very careful, because the pressure gradient is higher, then you're gonna have a more sort of a venturi effect. As you pull the catheter too fast, air gonna suck in. So you need to be careful. Okay, so physics, guys. So if you're gonna do that, now the LV chamber pressure is 120, 130, air pressure 0, you take it out, air gonna suck it in. So pull it out catheter very slowly and make sure you flush. Okay. I don't mind you guys doing that, but I need to knowing what can happen. So this is important teaching. Okay. Anything else? Okay, great. Good
Thank
case.
you.
Thank you.
Thank
For a
you.
good case.
Next,
If you have any question, you can ask us, then we'd be happy to give you an answer as well. You're entitled to the question too. You did a case.
코딩 업. 패스워드 좀 알아봐줘요. 유튜브